counselor, certified problem gambling counselor, internationally certified gambling counselor. I have a small private practice. Those are my fields and areas of interest, AOI. For what it's worth, everything that's up today that's being brilliantly streamed and archived and distributed and recorded and all that other stuff by the university, who are doing a fabulous job. If you want to see all the stuff, it's also up on my website, renegadecounseling.com, and there's a bunch of other stuff up there that's free. Take it, use it, help somebody with it, and if you see something that's wrong, tell me. I will grow from that. Screening, what's the point? We're trying to find somebody, and it's important to remember we're trying to find somebody. We're not looking for the problem. We're looking for the person who has the problem. I learned from somebody much wiser than I will ever be that every client has a face. There's a person behind that case number, behind that folder, behind that serial number we give them, or an incident. What we want to do in the screening world today, and this presentation is an example of brief screening. In the time of this presentation, we will have been able to do a brief screening for gambling disorder using the tools that I'll show you today. What do? First, let the client know what we're talking about, rather than just moving to the next piece of paper on the clipboard, rather than just moving to the next page of the computer device that you're entering all this data in. Tell them what you're going to ask about. Would you mind if I talk to you about your gambling? I have a small 2-question, 3-question, 4-question. It would help me better determine what I can do for you. Be specific in the question. Tell me about your gambling problem. That is a non-starter. I went to counselor school for several weeks. That's a wide open question, but I'm not going to get any useful information. When I find out specifically what I need to know, I have to understand the client, I have to understand the disorder, and I have to understand how the tool is going to work. Why would I screen? I want to find clinical interest items, not general history. I'm not asking for a biography. I want to find items of clinically significant interest. I want to document a baseline condition. When they were admitted, they were here. 30 days later, they were here. 6 months later, they were here. I can use these screening tools to track the client's progress myself, and I can give the client feedback. Say, 30 days ago, you were here. Today, you're up here. Yay. Part of my job is to motivate them to continue to do something that's very difficult. I've been working in the addictions field a long time. Addictions are very uncomfortable, not only for the client, but for the people around them. I want to motivate them to continue. Wow, you've gone 2 weeks without a cigarette. Yes, good on you. Don't stop. Keep it up. The screen shapes the treatment plan. That identifies the peaks and valleys, what I have to worry about and what I don't have to worry about today. I can sequence them, I can prioritize treatment, and I can motivate the client. I have to be able to attend to the client in the moment. In counselor school, we say meet the client where they are. Right then, they're experiencing some sort of crisis, or they would not be talking to me. Nobody talks to me. Well, maybe that one guy on the bus, but we have to meet them where they are as a precursor, as a beginning. Screening is not treatment. We have to look at it through a couple of lenses. 3 in this particular case. Biopsychosocial. What is their physical health? What are the impacts of their addictive behavior? Psychologically, how does it shape their perception of their environment? Sociologically, how does it interfere, impact, or impede their successful relationship with other people? I'm looking for clinically significant impairment or distress. I wish I had come up with that phrase. That is word for word from DSM-5, which tells me what I need to know. I don't care what color their house is. I'm looking for clinically significant impairment or distress. Suicidality. The population of people with addictive disorders, highly vulnerable to suicidality, ideation attempt, Gamblers in particular are notoriously high risk of suicidality and a history of trauma. In my experience and observation, if you peel an addiction, the first layer, you're going to find a traumatic history underneath that. Those are the issues we have to deal with, or they will not get well, or better for that. Here's a pretest. Everybody in here is capable of administering the screens I'm going to give you today, but let's find out how naturally talented you are already. Are you ready? It's pretty exciting. This is a brief screening. Can you find the face? This is the equivalent of finding a tree in a forest. In that coffee bean thing, can you find the face? We've got one. Okay, good. It's tough because it's small and you're way in the back. I'll help you with this one. The next one, you're on your own. And I did not pose for that picture. That's what we face every day. If your email basket, if your waiting room, if your office, if your agency is the bag of coffee beans, you're looking for something. And we get overwhelmed by our physical surrounding. If it happens to us and we're reasonably healthy, imagine what it's like for the client. They're on fire. They're looking for a treatment provider. They're looking for someone to listen to them. They're looking for someone to help them. They face the same challenge we do. We have to meet their screen. Did that old bald-headed guy listen to me? Did he care? Did he know what he was talking about? Did he make a difference? If not, he's not coming back. Now, can you find the problem gambler? This gentleman, yeah. But if only in his previous occupation. As a real estate developer, he takes a chance. This is going to go up, this is going to go down. This area is hot, they're going to put in a freeway over here. How about this small child who's playing a slot machine in her family's basement rec room? She's being taught how to gamble. Is she at risk? Absolutely. Does she have a problem yet? We don't know yet. We don't. Bernie Madoff, oops, I beg your pardon. Did he gamble? Now, some people think he was the smarter gambler because he used other people's money and not his own. That's criminal behavior. Okay, brief screening. Why do we do it? We're trying to screen and screen and screen. I'm a treatment provider. My intake packet is 26 pages. My clients get counselor-induced carpal tunnel syndrome just filling out the forms. And they're big instruments, and I went to counselor school, and I say, man, if you complete this, I'm going to know so much about you. The client doesn't care. He wants to know if I get it. I can do that in a brief screen. Helps me understand it, helps them understand it. And I can screen and screen and screen. They can fill out forms in this enormous room for hours. I missed somebody. This is why we do what we do. Why should I screen for gambling? Everybody in Nevada gambles, true? No. Well, nobody I know has a problem. Is that a screen? How would you know? We couldn't even identify the picture of a problem gambler. No track marks, no BAC, no breath. I have no chemical test. There's no clinical test for that. It would take me a long time to drink $60,000 worth of Jack Daniels. I can drop $60,000 at lunchtime. You would never know. First of all, evidence-based research for DSM-5 update found that this is clearly the first and most significant non-substance-related addictive disorder. It is the first and only currently in DSM-5. Substance-related and addictive disorders, and gambling disorder is the first one ever. There's enough basis, there's enough research, there's enough common sense to say, I don't know much about this, but it looks like an addiction to me. It looks like an addiction to the client, too. Similarly, the legislature has now realized that in the same way that we occasionally come up with diversion court problem or processes for people with alcohol and drug problems, for people with mental health problems, that there is now an avenue, it's not fully completed or perfect yet, for offering people with gambling problems assistance. Locking them up does absolutely no good for anyone. When I was in prison, I learned that. Parenthetically, I worked in the prison. I got to go home at night. But generally, locking up people with addictive disorders does not work, in my opinion. Why should we be interested? Nevada scores pretty well compared to the rest of the country in the severity problem. We have fewer social gamblers, and we have quite a few more, generally twice as many people with clinically significant impairment or distress related to their gambling behavior. That is not surprising to me. Previously, they would have met DSM-4 criteria for the disorder. Look at how many people in our population would have met the old criteria, and now how many more will meet the new criteria. We have to recognize that the at-risk population around us is growing rapidly. The nature of gambling is growing and changing rapidly, and we have to be able to respond to that in an intelligent way. I stole this part. Use, abuse, and addiction. We know those terms from the general field of addictions, generally substance-related. There are a lot of people in this country who can walk by a slot machine and play. There are a whole lot of people in Nevada who can't. What's the purpose of SBIRT? Screening, brief intervention, referral to treatment. And we'll walk through that process in order to show you some of the tools. A repeated brief intervention, or just one time, hand them a pamphlet, hand them a phone number, give them an internet link, something, or you can repeat it. Significantly, we're talking about a short conversation. That means I'm talking to someone. That means I have to listen as well as talk. I have to learn a little bit about the client's current condition. Feedback. I hear you saying this. Motivation to change current behavior if they're in distress. And advice. Believe it or not, some people will listen to us if we tell them, based on our experience and observation, what we've learned and how it can affect them. Brief therapy or additional treatment. I'm a counselor, not a therapist. I do brief work all the time. We're adding gambling screens to something now called SBIRT or GBIRT. We don't even have the name right. It shows you how early we are in the process. But I think because it's an identified addictive disorder, I think it belongs in this process. We're already doing some of this for other addictive disorders. We can do it for gambling as well. We also have to learn how to ask smart questions. The first gambler I ever found in my agency was when I asked a real Columbo question. So where did you get your DUI? Parking lot of the casino. And here it comes. Here comes the burst of sunlight. Oh, do you gamble? When I think of all the tuition I wasted to learn how to ask that question. Oh, do you gamble? And he's, oh yeah. I'm there all the time. And oh, all the time? Tell me what all the time is. I gamble 6 days a week. Oh, so how you doing? Not real well. But I get free drinks. Screening's important. Also, our ability to do that coffee bean thing is important. This is one kind of screening. Everybody goes through it. It's an automated process. However, and I love this slide, this one is, I'm going to take with me. You can't see it, but on the back of that guy's t-shirt, it says, "You can't drink all day if you don't start in the morning." And you know, he's right. But I already know something about this guy just by observation. Oh, in much the same way, if I saw somebody wearing a Red Sox baseball hat, so how about them socks? See, I didn't have to go to counselor school at all. I saw that, I made the connection, I asked a question. If I see a guy with a drinking t-shirt, Jack Daniels hat, Jack Daniels t-shirt, Jack Daniels belt buckle, bottle of Jack Daniels in his hand, so do you drink? The risk here is that he's going to think I'm an idiot. But he's going to answer me, well, yes, I do drink. Oh, how's that working? This is a real client. What's interesting about this client is the binder he's holding is his IOP treatment program for problem gambling. The door behind him is the door to my office. He came to group wearing this shirt. I said, okay, it's worked real well for you so far. However, let's think about this from a caring profession. Maybe this is the only shirt he has. In fact, I asked him to take it off and wear it inside out, because it was also working on the folks in the group. His addictive disorder does not occur in a vacuum. It affects other people. We know that in the substance world already. The purpose, not just to find somebody with a problem, but to rule out the problem. We don't want to unnecessarily interfere with a treatment protocol that's working by adding something that he doesn't have or that he doesn't worry about. We have certified problem gambling counselors in Nevada. That took a very long time to bring to fruition. These are the people who can competently determine the nature of a gambling disorder. Here are the screens I'll talk about as quickly as I can. The first two with regard to suicidality, plaid pals and sad persons. You're probably using something like that if you're a clinician already. A quick mental checklist of things that you want to cover to determine the relative severity or risk of suicidality with this client. And I'll show you what they are. There's also a paper instrument that I'll show you too. Here's the first one, suicidality. Why do I worry about it? Gamblers are high risk. Those numbers are a little bit old. Over 20% of problem gamblers have attempted suicide at some point. About 25% have related problems that would contribute to suicidal ideation. 22% plus now recognize that they have legal problems related to their gambling behavior. If a client has ever been handcuffed as a result of their behavior, they have a problem. If they've been handcuffed because of alcohol, they have an alcohol problem. If they've been handcuffed because of heroin, cocaine, and meth, they have a drug problem. If they've been handcuffed as a result of their gambling behavior, they have a gambling problem, bar none, in my experience. Be advised also, there's a similarly high rate and risk of domestic violence among problem gamblers and their families. The Plaid Pal screen, do you have a plan? Does it involve lethal means? Are they available to you? Are you now or have you recently been ill, seriously ill, surgery level of illness? Are you currently depressed, or do you have a history of depression or diagnosis? The number one indicator, have you tried to harm yourself before? Are you alone, living alone? Have you recently experienced a significant loss? Death, divorce? And don't forget pets. That matters to some people. It really does. And you have a substance issue currently. I use Plaid Pals. I just run it through my head. Every client I interview, I've asked them about those at one point or another. Do not dismiss the severity that they describe. Sad persons, this is beginning to show some wear. It's about 50-50 now. It used to be predominantly higher risk for males. Greater risk at both ends of the age spectrum, adolescents and people older than I am. Depression, previous attempts, ethanol, alcohol. Psychotic behavior, these are some accidental self-harm events where they didn't have the intent to do what happens. Are they alone? Do they have an organized plan? And are they ill? Here's the paper instrument. It's in your handout. It's in the stream that you can download and on my website. Have you ever thought about it or attempted? How often? Have you told someone? Have you threatened to do it or warned someone? And how likely is it today, now? What's your current risk level? I've had clients who I do not allow to leave my office because of that. Gambling screens, I love this one. 2 questions, it's very simple. You don't need a paper instrument. You can do this in the back of a police car. You can do this in an emergency room. You can do it in a detox center. Have you ever lied to anybody about your gambling behavior? Yeah. Or I don't tell so-and-so about how much I lost. Oh, great. That tells me you are deceiving people about your gambling behavior. Strike 1. Have you ever felt the need to bet more, to go back and get more, to earn more money, to put everything you have on it? I'm all in on this one. If it accelerates or escalates or avalanches on you, that's an indicator. The beauty of this instrument is, if they answer yes to one question, they're 90% likely to meet full diagnostic criteria for the disorder. One question, that's a brief screen. If they answer yes to both, they're better than 95% likely to meet full diagnostic criteria. Thank you, Dr. Nora. BBGS, developed by the National Council, 3 questions having to do with significant characteristic behaviors. Do you experience difficulty when you're trying to cut down? Withdrawal. Have you tried to hide it? And have you ever had to get a bailout? Payday loan, borrow from your wife, borrow from your husband, borrow from your child's piggy bank, sell a child's toy, pawn your wife's car. And the clip. The NODS clip is a short form of the NODS, which is probably the benchmark full screen. It's a large instrument. The North Oaks National Opinion Research Center Diagnostic Screen for Gambling Disorder. 3 questions drawn from the diagnostic criteria that will give you an indication that this client is at high risk. There are paper versions of the big instruments that have been updated and validated for DSM-5 criteria. You can Google them, you can find them in your information packet. The NODS SR, self-report, and the NODS FMR, family member report of Mrs. Collin, have you seen Collin doing this, and this? That's a collateral report that indicates to me that Collin might have a gambling problem. CCSM and HUDAS are drawn directly from DSM-5. These are general purpose screens that will give us a bucket of information in a very short time. The transition from multi-axis assessment, we're still asking people for Axis 5 indicators, which are no longer current or useful, quite frankly. I didn't get a lot of use out of the GAF, the global assessment of functioning, but I get a tremendous amount of information with regard to how impaired by you in your daily life. And cross-cutting symptoms measures. Here's why this is important, in my opinion. One questionnaire, 13 questions that will give me full information on these kind of problems. Would I like to know this up front and quickly and easily about my clients? Would I like to know if they are experiencing depression? Mania is common among problem gamblers. What is their suicidal ideation? How are they sleeping? Do they have a substance problem? Are they experiencing psychosis? On a one-page instrument. This is brilliant. I love this thing. And if they meet a threshold, there's a level 2 screen right behind this that'll give me more specific information about depression, anxiety. In problem gamblers, generally you will see simultaneous, concurrent anxiety and depression. You will see sleep disturbance, and you will probably see some sort of eating problem. The WHODAS, 6 dimensions. How do you relate to other people? Can you get to work? Can you feed yourself? Can you self-care? This will help me determine a level of care later. Can this client survive an IOP, outpatient, or do they need residential treatment? Something that is not in your packet, it's not these guys' responsibility. I added this. The ACEs instrument, adverse childhood experiences. What is their history of trauma? That's a lifetime deal. These wounds need to be treated if we're going to have success with problem gambling disorder. The other thing we need to know is not just what's wrong with this guy, but what's right with him. I include a scale of resilience. What are your positive strengths? What are your assets? What can you draw on? Do you have a social supportive environment? Do you have friends? Do you interact well? Were you raised with good parenting models? Did you grow up resilient? Brief intervention. Here's what the numbers show. I'm sorry, I'm a geek. If you just, and it can be something as simple as, do you think you could not gamble today? Do you think you could not gamble until we can get you over to talk to fill in the blank? Can you not, I don't want to get sued, but do you have to go to Dottie's today? Is there somewhere else in town that you can cash your paycheck other than the cash cage? Simple, small, common sense approaches that can really make a difference. However, the numbers show if you can get motivational enhancement, not motivational interviewing, motivational enhancement, take what they will already use. What's important to you? And can you build on that? What was your most recent success? What made you feel good about yourself? If you can do one motivational session and 3 sessions of CBT, cognitive behavioral therapy, I'm a CBT guy across the board, they stand a good chance of making it 9 months. In gambling addiction world, that's a great deal of time. 9 months free of any addictive disorder is a long time. Some days, quite frankly, 24 hours is a really long time. Brief intervention works at reducing the behavior. We're not going to extinguish the behavior in 3 sessions, but we can reduce the behavior, and if we reduce the behavior, we reduce the harm. Who can do these screens? Anybody in this room can do the screens. You don't have to be a diagnostician, you don't have to be a licensed professional. However, there is scope of practice and scope of competency. Even if I'm, for example, a clinical professional counselor, if I have not had any training or exposure to gambling disorder, I might want to refer to someone who does. If I'm a social worker, if I'm a psychiatrist. Anybody who graduated from Harvard med school is a doctor. There's only a couple of them I want taken out my gallbladder. They've been school trained in the particular discipline. They recognize and can work with patients who have that issue. I would look for them. CPGCs, certified problem gambling counselors in Nevada, for example. Or add them to the treatment team. There's a lot of stuff that I can't and won't do. If I can add a psychiatrist to the treatment team, I can help with some co-occurring mental health disorders that are beyond my scope of practice. Referral to treatment. Where do I start? Who do I know? The great thing is, most gamblers already know. They see an 800 number on a pamphlet in the casino, in the 7-Eleven, at the ATM machine. The woman down front, Carol O'Hare, Executive Director of the Nevada Council, had a great deal to do with that. Get it visible. Offer them the lifeline. They don't have to grab it, but they have to know a lifeline exists. She's a good referral source, the hotline for the gambler, and the National and Nevada Councils. They all have resource lists of who in this town, who in Henderson, who in Reno, knows anything about this stuff. Who can I talk to? Who can I refer to? Who can I ask a question from? Who can I put on the treatment team? Now, what are your comments or questions? And if you have a question, great. If you have an answer, even better, because I brought a pad of paper. What is your experience with problem gambling? Do you encounter these people as part of your daily work? Do you live next door to one? Are you married to one? Are you one? Do you care about one? You can't be in Nevada without being exposed to it. Yes, ma'am. You're a star now.
Apparently, yes. I just wanted to ask, is there a screening tool that you would recommend for juveniles? Specifically, that's the population I work with. So, although they shouldn't be gambling, however, we have many that, get into, the casinos, underage, whether it's prostitution they start with and then they, bend out or it goes into a different direction. Is there something we should be putting into our assessment for them?
Simple answer, yes. Those tools are available. I will have to send it to you if you'll email me. There are adolescent scaled instruments for most of what I've described. There isn't an adolescent version of the LIBET, but there's a full clinical screen that is scaled and validated for adolescents with gambling problems and the mental health problems that they would most commonly experience. That's all right.
So my question is, what are the outlets for family members that have a loved one that has a gambling addiction? Do they have any support groups, in order to help not enable them, that they don't, know they're enabling them, or, something that they can do that can just help in the road to recovery?
Yes, there are. There are some that are clinically based, but the first one that leaps to mind for the gambler is Gamblers Anonymous. And for the family member or concerned other, Gam-Anon. There is also an adolescent Gam-A-Teen? Yeah. But because of the reality of the fact that maybe the gambler's not ready to do anything yet, but the family member is already experiencing the trauma, the secondary effects of this, vicarious trauma, actually. There are opportunities for that. I would start with the self-help community. In our group, we do a family member night. We enroll family members, and they come to one group with their family member. So they've got a lot of business to work on. Some of it's very effective in the group environment, but absolutely in couples therapy, they have a lot of repair work to do. And if the gambler won't participate, the family member can. They can get well if they want to. That's a great question. Yes, ma'am.
Hi, Carol O'Hare, Nevada Council on Problem Gambling. I just wanted to comment on that about the resources. We do have a display booth here at the event. We have the full list of all of the treatment providers in Nevada that are CPGC. We have a list of all of the support groups in Southern Nevada. And when Colin mentioned about treatment, one of the things that we were able to accomplish in Nevada is to get some of those treatment resources funded. And so treatment is free. Gamblers don't have resources when they reach the point of needing treatment. And what Colin didn't make a point of, because he's very humble, working in this environment as well, he also assisted, and as did many of the providers, in advocating that that same treatment's available for family members and it is free for them too. So if they're going to a state-funded clinic, they can get mental health counseling. They do not have to have the gamblers the ticket to get in the door, and that's a really important part of what needs to happen. Also, the BBGS, which is the 3-question screen, is on a cool little magnet and free at our booth if you'd like to have something just to take with you to stick on the side of your file cabinet to remind yourself what that screen is.
Thank you, Carol. And I encourage you to use that magnet. If you don't see all that many gamblers, but if you get an indication, if you've got that on the wall, you can leap right in there. You don't have to go down the hall and get the binder and say, oh, okay, what is this tool? You just get this much window of opportunity. It's a brief window as well as a brief screen. And if you're there at the moment, you can change somebody's life. It's magic. Okay, thank you for your time and interest. All this stuff is on this, and I have to thank 2 people in particular, Stephanie and Heidi, who did a wowie-kazowie job. And believe it or not, I'm done under time, and they knew I was going to run long. Thank you for coming. Please.
Videotape it.
Yeah.
I did that the old school way. Are you guys all set? In terms of what we're talking about, we're all solid? So we're probably gonna have about, depending on how fast I talk, 20 minutes for like the mini panel discussion-ish. And so I'm gonna ask the 2 questions that I brought, like, prepped everybody for, and then ideally we'd have time for also audience questions, so just be ready for whatever that looks like. And the last thing I have to stress at every time is just to make sure that you speak from what works. So no pathway ever is represented as something that doesn't work for other people. And then again, language-wise, just to use more like the up-to-date substance use disorder and to stay away from the conversation of the disease model. Just because I don't want that to be a conversation that happens, because that's not our focus. So that's all I have. Any questions?
Who are the people that are attending?
We have, a lot of them would probably be professionals in the behavioral health field. I know that the police department is here as well. I don't know if they're necessarily in this room because they're thinking amongst other sessions as well. But yeah, professionals in the field, and then really just the,
So we're dealing with professionals in.
We've
Yeah,
never met
yeah.
Nyla Christian. We were
Hi,
talking on the
Nyla.
phone.
Hi, Nyla. Bree Rodriguez.
you guys just high five?
So what group are you with?
Buddhism and recovery.
See how good this mic works.
How does that work for you?
Can everybody hear me? Ish? We can make that a lot easier if we all just kind of come in if you can. That would be awesome.
Middle Eastern is, I mean, it's like, I would think the calmest people in the world.
You guys can ask questions, but we will not be asking questions of you, really.
You just
There
have
might
to-
be one.
It's a lot of, you can talk.
This isn't like a comedy skit where I'm going to pick you out. It's totally fine.
Learning how to dissolve some of those persistent addictive mind states. You know,
That's
a lot
good.
of what you guys do. You know,
Huh?
rethinking.
Well, thinking is,
Yeah.
thinking is a good start.
Right.
And that's kind of like what it is. It's like, just question, it's all about behavior. And why?
Right. So is Buddhism.
Yeah, I mean, it's, my sister and brother-in-law they met in.
All right, we're going to go ahead and get started because we have a 45 minutes, which is very little time, but we got this. So first, I want to thank you guys all for choosing this session. I know there are other sessions happening at the same time, and I want to acknowledge the fact that you're sitting here with us. I think the conversation that we're going to have here is really, really important, and it really does. I'm really glad I was here to hear Nyla speak. I think it really stems off of what she was talking about when we're talking about recovery and meeting the individual where they're at. And that was I don't remember the woman's name, but on the panel that was stated, and I think that statement is extremely important. So thank you guys for being in the conversation with us. I'm Irina, so I'm the founder and CEO of Choice in Recovery. And before we really jump into the presentation, I just want to kind of cover the format of what it's going to look like. I will talk about choice and recovery as a concept as well as an organization and how we really implement that concept. And then also following that, we're going to head over to the mini panel discussion that we're going to have. And so on the panel, we have Greg, and we have Barry, we have Bree, and we have Jimmy. And they all represent different pathways to recovery. And that's really great for us to have in the room, so you guys actually have a face to what we are talking about in the room, so it's not just a number or a slide on my PowerPoint. So thank you guys all for being here, and I will start the discussion in about 20 minutes. So thank you guys for just kind of hanging out and going through the process with us. So to start, handy dandy clicker here. A quick background on Choice in Recovery and how it started. And the reason that I talk about the background is so you guys can really get the kind of conversation that happens in the field and the ability of us to kind of combat that conversation by bringing the many pathways together. So it started about 2.5 years ago, and to make it really short in terms of how I talk about it, it came from a conversation that I had with a licensed professional counselor in the field. I'm very transparent about kind of where I'm at, and I actually chose moderation. And coming into the recovery field and saying I didn't take the abstinence route is very different. And I had a conversation with, again, the licensed professional counselor, and for me it was exercise and just kind of my own mindful and stubborn, I guess, personality allowed me to attain balance. And so I'm very confident in where I'm at, and when I talk about moderation, I'm confident that I'm able to do that. He looked at me and said, "You're delusional, you're an alcoholic, when you hit your lowest low you'll know, and 12 steps has been around because it's the only thing that works." And in that conversation, I held my own and I walked away thinking, what if he's right? What if I am all of those things? And what if this idea of moderation is a dangerous idea to ever propose? And luckily I'm really stubborn. So I went home and I researched, and I found out that there are other pathways to recovery, such as moderation management. There's smart recovery, there's women for sobriety, there's life ring, there's refuge recovery, Buddhist recovery. There's a bunch of different pathways. The issue is that we don't know about those pathways. And the initial point of Choice in Recovery was to educate the public so they actually knew that they had another option. What we found out later on, though, is that the reason that the public doesn't know that there's another option available is because professionals in the field don't know that there's another option available. So when I talk about that conversation, I don't talk about that licensed professional counselor as somebody that had any intent to harm me or to make me really question where I was at. I think he had that conversation with me because he did not know that there were actually other options available for recovery. And so in having had that conversation and then researching and finding that there were other pathways, I just called them up. I called up the facilitator for moderation management in Colorado. I called up a facilitator for smart recovery, for life ring, and got them all in one room. And we realized that they actually didn't even know about each other. And they started networking in the room oh, well, I have this person going to my meeting, and they might not be working out that well, so I could always refer them to your meeting. And then during that conversation, the moderation management facilitator said, what the public should see is what's happening in this room. And it was that discussion amongst the many pathways. And that's why we decided to bring together panels with representatives from the many pathways to, at first, the public, and then professionals in the field. And so out of that, our mission and vision was born. And so the mission of Choice in Recovery is to unite the many pathways to recovery and educate the public and professionals in the field about the options that are available to them. And then ultimately what we want to do is empower professionals in the field to really run a client-centered practice in which they empower their clients to choose a pathway that resonates with them. And so going kind of back to the presentation we heard before, that statement of meet the client where they're at. How can you meet the client where they're at and not know what resources you can provide that client with? Because that client might be, for me, I learned moderation at 20 years old, right? and I know it's below drinking limit, but sorry, the age restriction, excuse me, being taped live. I learned that at a very young age. And we think about the populations that we deal with, it's not always, it might not resonate with a youth for you to tell them you can never drink again. You know, I think moderation is more common than we think. It's just that we don't talk about it in the recovery field. People learn at some point to moderate. And some of us maybe have to do it more mindfully or whatever. But when you look at that conversation, we really have to be able to say if that individual is dealing with either a recovery coach or their counselor, we have to be able to provide them with another option if they say they don't want to take the more common route, which is 12 steps. And I do want to say I'm not at all against 12 steps. We actually have Narcotics Anonymous represented on our panel. In Colorado, we've also had Cocaine Anonymous. So we totally think that is a legit route. We just acknowledge that it's not for everybody. And we want to be able to have a conversation that works to hit the most amount of people. And for us, giving choice is how we can do that. Meeting the client with where they're at is giving them a choice to move forward with where they're at. So that's mission and vision. And then in terms of who's been represented, long list. We've had Narcotics Anonymous, Women for Sobriety, Smart Recovery, Life Ring, Phoenix Multisport, Moderation Management, Medication-Assisted Treatment, Harm Reduction, Cocaine Anonymous, University of Colorado's Collegiate Recovery Center, as well as we put an LPC or a doctor on the panel, and that's to legitimize the conversation that we're having. So when we're doing this conversation for professionals in the field, we put a doctor on there that talks about the continuum of care, who can say that there needs to be a choice and there are many pathways to recovery. Just out of my curiosity, how many people have heard of all of these pathways? Okay, so a minority in the room has heard of all these pathways. And that's what we want to switch, is we want to make sure that people actually know that all of these things exist. And it might not be something that you agree with, and I think when you're working in the field, if you're looking to have a client-centered practice, you kind of have to swallow that down. It's okay that you don't agree with it, but if it works for your client, that's the part that's really important, is that it works for your client. And then our goals. So our goals are to increase knowledge, change the conversation, increase referrals, and increase accessibility. So when we're talking about increased knowledge, that one is verbatim what it says, increased knowledge. We want to make sure that people actually know that there are many pathways to recovery. When we say change the conversation, I want to bring that back to how this was founded. We want to change the conversation from you have to go to this meeting to there are many options and you can choose. The thing that runs through my head when I was researching these pathways, I went to AA and I went to Smart Recovery and I went to Women for Sobriety. I went to majority of them. And if I had shown up to an AA meeting and it didn't resonate with me and that was all I knew about, I would have felt really hopeless. And we don't want to have that be the path or the pattern that's continuously repeated, is somebody showing up to a meeting knowing in their mind this is all there is, this is the only way to do it, this is all I've ever been told, and it doesn't work for me. And so that's why we want to change the conversation. And the conversation that we're talking about now is really the conversation between a professional in the field and their client. And I will say, though, that this conversation is also happening among the public. I have friends that, seriously, just last night I had a woman reach out to me about her substance use, and I was like, do you want to be connected with Women for Sobriety? And she did. And so these conversations are happening everywhere, but as an organization, we're talking about it between the professional and their client. And then when we talk about increased referrals, we're talking about where the professional in the field is referring their clients to. So we want to be able to refer to Narcotics Anonymous and AA and CA and all of the A's, as well as Smart Recovery and Life Ring and Women for Sobriety and Phoenix Multisport, all of them. And then the last goal, increase accessibility, that's a very long-term goal. So I would say that there's a gap in even what we do, in the sense that, say a client is like, yeah, I really want to go to Smart Recovery meeting. The issue is, because not a lot of people know about Smart Recovery in general, there aren't a lot of Smart Recovery meetings that individual can actually attend. So the ideal world is that once we increase referrals from the professional realm, these meetings grow individually, right? The meetings that do exist, those will grow. And then ideally there will be more individuals in that meeting interested in facilitating a meeting in their own community. And again, that is a very long-term goal for us. And then what I want to talk about here, and I'll burn through this kind of quickly, just on this slide. When we did an event at Denver Health in Colorado, that was a pivotal point for us as an organization because that event was very much geared towards professionals in the field. And during this event is when I collected a lot of data in terms of their knowledge, their perspectives, really like would they refer to the many pathways, what do they think about the many pathways. And I present the data here so everybody has an idea really of what that looks like in the field now and where it can go. And so with Denver Health, the only thing that I really want you to grab from this slide is that there were 54 in attendance. And the attendees included supervisors, licensed professional counselors, social workers, clinicians, government employees, and community members. And the years in the field ranged from 1 to 30 years. And we collected data by matching pre and post survey results. So we wanted to keep it anonymous, so we used the 4 last digits of the individual's phone numbers. And they would submit a pre-survey before they ever attended, and then they filled out a post-survey upon leaving the event. And the reason we did that is so we can really see the individual increase in knowledge as opposed to just like looking at the room in general. And the results were phenomenal. So this color scheme is not the best idea with the light blue on the white. But where I really want to concentrate is on these first 3 questions. And if you guys can't see what it says, the first question was, how familiar are you with the many pathways to recovery? In parentheses, I wrote things like smart recovery, life freeing women for sobriety, because I've realized in the field when I ask how familiar are you with the many pathways to recovery, a lot of times people say, oh, like super familiar. There's NA and CA and AA, and they go down that route. And so I kind of wanted to weed that out. The second question is, how familiar are you with recovery support programs in your area? And the third is, how likely are you to recommend a recovery support program to your client? So I talk about these 3 questions because that's where we saw a significant increase in the quantitative data that came back to us. So for question 1, for how familiar are you with the many pathways to recovery, we saw a 47% increase. For question 2, very similar to the first one, except we're now looking more at the area that individual is in. We had a 38% increase. And then for question 3, for how likely are you to refer, we had a 10% increase. And that 10% sounds small when we talk about the other numbers, but I think that's a very significant thing that a professional in the field came in there with one idea about referring clients and then came out with, oh, they actually would now refer clients to a recovery support service, which is kind of insane to think that they wouldn't have in the first place, potentially. And then the other questions where we didn't see a significant increase, I think is actually expected because those questions really describe the audience that would ever show up to a choice and recovery event to begin with. So the question was like, how important is it to have recovery support services? And then the last 2 were actually statements that people should have a choice in recovery and that these programs can be useful. So you would kind of expect that on a certain level that people that saw a choice in recovery event promoted would show up because they kind of believed in that idea and that concept, which I assume is kind of why you're here as well. You do believe in the many pathways, or at least want to learn about the many pathways, and you think that that knowledge would actually provide you with some value in the services that you provide. And then the next slide is looking at the qualitative data. So I was really hesitant to even ask the question because it seemed so like open-ended, which I know that's what a qualitative question is, but I asked the attendees what they think about the many pathways to recovery, just to throw it in there. I didn't really know what I was going to get back. And it blows my mind what we actually got back. And the one that I really want to concentrate on, there's 2 in here that really resonate and like are just shocking to me, is the second one that says, it's a great concept, though I only know a minimal amount. And this is a counselor that is 10 years in the field. After they attended the event, the response to that question was fantastic, and it's good to know that so many options exist. Another one that stands out to me is the 4th one down. It's great, need more, want people to utilize these resources, state government employees 16 years in the field. And then their post response was very necessary, we'll refer to clients and glad to know that there are more resources. And so we get really clear that people in the field, 10 years, like that blows my mind, 10 years in the field, and that individual probably didn't know about Smart Recovery or Women for Sobriety or Buddhist Recovery or Celebrate. Like, there's so many pathways that could have helped their clients had they known. But we have been in a culture where it really was going to 12 steps, which again, they support what we do even. You know, they're about it, and we do also see them as a very legitimate pathway. However, it doesn't work for everybody, and as a professional in the field, you should just accept that. And I think maybe there's been a resistance to just accepting that it might not work for everybody, so what is the other option? And then just to briefly cover the pathways. So normally a choice event has about 8 people on the panel. I'm lucky to have been connected with Nyla, who connected me with these individuals, so we have a mini panel. But I do really want to cover just really briefly the other pathways as well, and some of this will be overlapping with representatives that we have on the panel. So Women for Sobriety is a support group for women with a holistic focus. I think it was also mentioned earlier, the idea of recovery not just being around substance use, so the SAMHSA definition, and you're looking at the person as a whole. And so Women for Sobriety really does represent that kind of approach to it, to look at the woman as a whole. And from my experience in attending the meeting and working with facilitators, they use very empowering language. So you might go to a meeting and how it starts is like, I'm Irina and I'm a competent woman. And that's the kind of conversation that you're having, and you are having a conversation in the room. And then you have LifeRing, which is self-help, secularity, and sobriety. They actually did stem from 12 steps, and they just wanted to have more of a secular version. And they really are about, again, the entire individual. They kind of create their own like I don't want to say self-help book, but just basically kind of a plan for themselves personally for their individual recovery and just their life. Then we have Smart Recovery, which is a self-management and recovery training. And it's a science-based mutual support group and utilizes the power of choice. So you're kind of using cognitive behavioral therapy in this case, and you're looking at, why am I making the choices that I'm making? So if I did use, why did I use? Or if something else is happening in life, like what choice am I going to make there? So again, they're looking at skills that are not just for recovery from substance use disorder, but skills that help that individual as a whole in their life. And then we have moderation management, which is one of the more controversial groups on the panel, and I'm totally aware of that, and that's totally fine. That is a support group designed for problem drinkers seeking moderation. It is for problem drinkers. People hear moderation management and they freak out. How am I going to moderate heroin use? You're not going to do that, and that's not the point of it. And it is seriously just for alcohol. I'm from Colorado. Marijuana is legalized. They don't talk about marijuana even, because it wasn't designed for that, and it's very clear that it wasn't designed for that. And in bringing moderation to the table, I had to kind of combat the conversation that I had, and this idea of, if we talk about moderation, are we putting people at risk? And is it a dangerous concept to even talk about? And the first event that I ever did, I had to like really think about that. Moderation management was represented, and the fear was, if there's a chronic user in the audience and they hear I can drink, they're going to go ahead and choose moderation management. And that's a scary concept to a certain degree. And I've kind of approached that from 2 ways. The first one was I had proof that wasn't the case. My best friend's mom was in the audience for the first event that I ran, and she is a chronic drinker. And she was in the audience, and after the event, she came up to me and she was crying and hugging me and thanking me for what I was doing, and she went to the Women for Sobriety table. And moderation management was right there available to her. The other thing that I look at is if you're having a conversation with a client and they're so set on this idea of, I don't want to quit, I want to moderate, I think I can learn, let them try in a very supported, structured manner. And if they fail, great. They know for themselves that they can choose something else. And so that is one that I really did have to think about. But I really think if you have somebody that you're dealing with that really is as stubborn as I was, then give them something and let them have a structure. Because when we talk about moderation, they talk about how many drinks is considered moderation, and like you approach that. They also ask to do a 30-day abstinence. like program with them, and that's to look at if like what was taking up the time, like how were you using your time drinking versus now you have all this time when you're abstinent, what other hobbies are you taking in, and it really utilizes mindfulness in that. And so I think, and I talk about that one a lot because it is controversial, and that's why I want to really approach the points of that one. And then we have Phoenix Multisport, not here, unfortunately, maybe one day. So that is a supportive, physically active community for individuals in recovery, or just for individuals that just don't use. And so this is a group that started in Boulder, Colorado. They're in Denver, Colorado. They're also in California now, and Massachusetts, and I believe another state as well. And it's a group of individuals that likes to like road bike and CrossFit and do yoga and snowboard, and they come together and they do really great activities, and they support each other in their recovery. And then you have CU Boulder's Collegiate Recovery Center, and that is just a resource that is supportive for the community as well as students. And I love that they actually are open to not just students on campus, so it's not like, oh, you paid your tuition, now you can utilize our resources. They're open to anybody in the community. And I went to CU Boulder myself, and they did not exist at the time that I was there, but having visited now and seen that space, it's phenomenal. That students that are either struggling or are going to CU Boulder, which is a very stigmatized university for the amount of partying and drug use that happens there, they now have a space where if that's not what they want to participate in, they can link up with other students that also don't want to participate in that lifestyle. And then we have Celebrate Recovery, which I've actually never worked with in Colorado. So this is different for me, and that's a Christ-centered 12 Steps program, and we'll talk more about that on our panel, as well as Buddhist Recovery, which is a Buddhism recovery group that looks at the correlation between 12 Steps and Buddhism. So again, you'll hear more about those in very quickly. And then last slide, really for me, we have medication-assisted treatment, which is a combination of behavioral therapy with medication. That one kind of stands out because you're seeing, the word treatment in the name. I believe that there's kind of a shift in how we talk about it to medication-supported recovery. I have not updated myself on that yet, but I'm just going to plant that seed. And the reason that I included medication-assisted treatment really was because it's extremely stigmatized. And it's not only stigmatized maybe with the public, but it's stigmatized in the recovery field. It's stigmatized among peers sometimes. And so I really talk about this one and have them normally represented as well, because we do have to accept that for some people, medication is the route. And I have a video for Choice to Recovery that I definitely welcome you guys all to watch. It's just on the website, and we'll talk about that site later. But the representative for medication-assisted treatment says one thing in there that like really got me, and she said that 80% of individuals that go into a medication-assisted treatment, like 80% of them then get a job. And that's huge, because again, recovery isn't, like, the demon is never alcohol or heroin or any of that. It's none of that. Like, and we demonize drugs and alcohol, but it's not actually, that's not the thing that we should actually be looking at. We need to look at what the individual is dealing with. And the fact that an individual can go into an MAT program and attain a job because they are on medication that allows them to do that, you're actually hitting the individual as a whole. And then they can also deal with why are they actually utilizing the drugs that they were utilizing. And then also harm reduction. And with harm reduction, you're looking at reducing harm, helping prevent the spread of disease and death. For me, when I heard about harm reduction, I thought this was just a place you show up to and get clean needles. And it's not. And it's really great. There's actually, I didn't get to talk to the representatives here, but in Vegas, you guys have Track B Exchange. And that's off of Charleston Boulevard, because I did my research. And same thing with the Track B Exchange group, as well as the Harm Reduction Action Center in Denver. It's not just a clean needle exchange. There are educational programs there. There is HIV testing. They're like overdose prevention, everything. So it's a bigger resource than just clean needles, and I think people should know that, because I think a lot of times they're stigmatized because that's all people think that these harm reduction action centers do, and it's really not. So without further ado, we're going to move on to the panel discussion. And because we do have kind of a short time frame here, and it looks like I have about 20 minutes left, which is great timing, there's questions that I will ask, and then once we kind of get through that, I'm totally open for questions from the audience. I think it's really great to be able to have a response from a representative from the different pathways. So ideally with time, we will have that available to us as well. So the first question that I would like to ask to all of you, and we can just start Greg and we'll just go down the line to Jimmy, is what is it about the pathway that you represent that works for you? And in answering that, please re-mention the pathway that you represent.
My name's Greg Pergament, representing Buddhism and recovery. And I gravitated to this pathway of recovery really as a way to look at my behavior. I had been long-term 12-step recovery, and it was working. But my behavior was still not quite in line with the person I knew that I could be. So when I started studying Buddhism, I had them parallel. What I found was Buddhism is a path basically of embrace and cultivating that which is wholesome and abandoning that which is not, harmlessness. Right? And so the way we realize that is through meditation. So I started to do that, and then I realized there's just a lot of correlations between 12-step recovery and Buddhism. So I met a couple of people, Kevin Griffin, one of the pioneers in the Buddhist Recovery Network. There's a website where you can access these groups. It's international now. There's only one in Las Vegas, our group. But that enabled me to talk more freely about how Buddhism could help people, like a lens, if you will, to view 12-step recovery. Because a lot of people didn't want to give up the whole 12-step model, but they wanted to look at it with a little, maybe a broader perspective, especially when you touch on more religious kind of groups that tend to have that tone to them. It's about how you act in Buddhism, what you do, and being aware of how you act and the implications of that in your life, and eliminating suffering also is a main aspect of Buddhism, as well as recovery. So they fit really well for me, and I love it. Thank you.
I'm Barry. I'm Regional Coordinator for Nevada for Smart Recovery. In my particular instance, I wound up going to SMART because it was science-based and actually used the cognitive behavioral therapy part, which made sense to me. Everything became logical, and I had an understanding of what I was doing. And we're worldwide. We kind of ask the question like, why? Why are you doing this? Why are you injuring yourself, or just your behavior? We want you to look at your behavior and see if you can come up with reasons why you need to do this. And that's proved extremely effective for me and a lot of other people that I know, and that's why I like the SMART program.
Hi, I'm Bree Rodriguez. I'm on the board of directors for Women for Sobriety, and also a woman in recovery. And essentially, when I got sober, I was looking for an organization, so of course I relied on Google to, right? What do we do without that? I put in women in sobriety, women in alcoholism, and the organization Women for Sobriety came up. So I went onto their website and read through their mission statement. And in terms of what speaks to me and what works for me, I just want to read 3 sentences from the mission statement, because when I read those sentences, it really distilled for me what I was looking for in a recovery organization. Women for Sobriety is an organization whose purpose is to help all women find their individual path to recovery through discovery of self by sharing by sharing experiences, hopes, and encouragement with other women in similar circumstances. Very important. We're an abstinence-based self-help program for women facing issues of alcohol or drug addiction. The New Life program acknowledges the very special needs women have in recovery, the need to nurture feelings of self-value and self-worth, and the desire to discard feelings of guilt, shame, and humiliation. I read that, and that really spoke to me, because women do have oftentimes unique issues that they deal with when they are recovering or in recovery or seeking recovery that can be different from men and society at large. And because of that, it is great to have an organization that is run by your peers and that can help you gain that positivity, that empowerment, and that self-realization that perhaps you were lacking growing up, and certainly during that time period when you're in the midst of your alcoholism or drug use. It also spoke to me because at the time it was important to me to find an organization that resonated with the thought that I had of myself that alcoholism, alcohol use disorder, is something that I have, it's not something that I am. And that was put out in black and white for me, and as soon as I read that, I latched onto that, and the years passed, and as I said, now I'm on the board of directors.
Thank you.
Awesome. My name's Jimmy Monahan. I represent Celebrate Recovery. What has drawn me to Celebrate Recovery was being able to explore a named higher power and being able to share commonality in faith and be able to struggle with that faith and also be able to get poured into and discipled. What keeps me there is my faith and also that it's a systemic program. It doesn't just address the substance use disorder. We have programs for our children. We call them pre-recovery programs. Celebration Place. We have programs for our teenagers. We call it the Landing. And it's familial. So it's not just substance use disorder. It's whole person, whole family. And that was really attractive to me coming up in a place to where often my recovery was almost secret. And I couldn't share it with anybody. I recover out loud, and Celebrate's allowed me to do that. We're in 30,000 churches worldwide. Over 2 million people have gone through the STEP studies, so it's what works for me.
Thank you to everybody. And before I actually ask the next question, I just want you to know kind of what Las Vegas looks like when we talk about these pathways. Smart Recovery has 2 listed in Las Vegas. LifeRing, which I mentioned on a previous slide, it has, and I contacted them. I have not received a response, but there was a meeting for the homeless listed at the Care Complex off of 4 Master Lane. Moderation Management has a meeting in Reno, Nevada, and Harm Reduction, the Track B Exchange service that is also represented here at this conference. And so the next question to kind of follow that up is, how does someone bring your pathway to their community if they are interested in that pathway? And we'll mix it up and start with Jimmy and then work our way back.
All right. Keeping us on our feet. The easiest way to start a Celebrate Recovery is to go to celebraterecovery.com. There is a group finder and a state rep finder, and you just click on the tab and it'll give you the contact information form. I also happen to be the state rep for Nevada, so you would contact me, and I will come alongside of you. There's no charge to that, obviously, and I will walk with you on how to start that up. So that's how you get Sobriety Recovery, celebraterecovery.com.
Perfect.
Or Jimmy.
Jimmy.com. In terms of making contact with our organization, womenforsobriety.org, I do have business cards here with phone number, all the pertinent information. It also has our 13 affirmation statements on the back as well. Please take a few of them. Don't limit yourself to one if you have clients, friends, associates that you think might want some. In addition, I've got brochures here as well that talk about if you are a therapist, counselor, you have a facility that you'd like to start a meeting at, you'd need to contact our organization, and we can go ahead and get you started with that. We are in the process of starting a meeting here in Las Vegas, for which I will be the moderator as soon as I get a few moments time. So if you want to have contact with me, you can either come up to me after the meeting, give me your card or your number, or feel free to contact the organization. They can put you in contact with me via phone or email. Generally, our meetings are moderator-led, which means a woman who's in recovery herself with at least a year of sobriety puts in an application with the organization, needs to show a familiarity with the program, etc., and then she can start up her own meeting, boom, as soon as she has been approved. And for organizations and facilities, You don't have to be in recovery, obviously. You just go through our headquarters.
Smart Recovery, as Randy said, there's 2 meetings in Las Vegas and a couple up in Reno. If you wanted to become a facilitator or start a SMART meeting, you can go online, and they have a program that I think takes about 4 or 5 weeks of online questions and answers, but you could then become a facilitator and either use it to handle your own clients or start a meeting yourself. And it's really very simple. And one of the great things is also you can have a meeting online. They do meetings online all the time, and it's worldwide. So there's a lot of things that you can do, and you can always call the main office in Ohio.
Thank you.
For Buddhism in recovery, you can contact me. There's only one Buddhism recovery group in Las Vegas right now. It's been going on for 9 years. I had hoped it'd been bigger by now. Refuge recovery is another asset in this kind of venue, this Buddhism recovery. There's 2 in Las Vegas right now that I know of. We haven't networked yet. A little more comprehensive and systematized. Noah Levine from LA is the originator and founder of that group. They have a book, and they have kind of a very system-oriented way of going through it. Buddhism recovery, there's a Buddhist recovery network. It's international. You'll see them all listed for different areas around the country. But really, if you're interested in Las Vegas and you wanted to start a group, it can be peer-led. You don't have to lead it. Like I lead my group because I'm ordained and kind of really got into the Buddhist aspect of it more heavily. And people seem to want that. They wanted to learn about Buddhism more like that. But you can grab a hold of one of these Buddhism recovery books and have a literature study anywhere in town and go through it and just discuss it. You do not have to be Buddhist to attend my group or any of the other ones that I know of. And you don't have to be in recovery either. The most interesting thing I've found from doing this for 9 years is people that come that, oh, I'm not in recovery. But they'll say, you know what? I do that a lot whenever I'm this, or I tend to revert to that when I'm, so we all have these impulses for making ourselves feel different from something outside of us, at least a lot of us do. And people tend to take a look at that before it gravitates to a full-blown substance use disorder, as it has for many of us. So.
Thank you. So we do actually have time at 12:19 for audience questions. So do you guys have anything that you want to ask? Right here, perfect.
I have a comment. I started working in the industry back on the East Coast in '89. And back then, we were providing patients with over 100 different support groups on the East Coast to go to. So back in 1989, it was AA, NA, CA are 3 of over 150. Here's the different list in their different areas, so it's not new.
Mm-hmm. And were those, what were the other ones outside of like the 3 that you listed?
Well, you had, again, it was on the East Coast, so you might have something out of Philly with the Reiners support group. You had things like even the Wiccans support groups. You had the Masons. You had Jehovah's Witnesses had their own. You had, I mean, there was a host of them. I would have to go back to my little filing cabinet and dig it out. I'm talking 1989 is we had it was well over 100 different support groups that people were going to. So it wasn't, there was one group that did whitewater rafting. You had motorcycle groups that would come up all the East Coast and would do their own type of, they would do an annual thing, and then they would have their chapters of their support groups, and they did the annual ones, all the state police would show up and see there's no drugs and alcohol, and they would be on their merry way, because they could stereotype them.
Right.
You had a roller coaster group where they would do that. You had Sailing the Sevens, and they would ride roller coasters all over the place. Sailing Sobers without Father Ashley in Maryland. So they would, you had the ocean, and they would do this. So there were tons of them because it was the same things that AA and NA's not working. I got to do something different.
And it's awesome to hear that there were and are communities that would do something about that. So I think it's great that you can provide us with an example of a place that actually did extend to different types of help. So I think that's really great. And thank you. Thank you for sharing that.
Hi, Nyla Christian. I would want to ask you, I had the pleasure of meeting you through Kimber at the Atlanta Prescription Drug Abuse Conference. And I think one of the most important things that we talked about at the conference is that there were many tracks. There is a prescription drug abuse track, there's a clinical track, there's a behavioral health track, but there was no recovery track. And how important it is to provide this information. Provide this information to end users, provide the information to professionals along the continuum of care, provide this information for families, for communities, period. But my question to you is how I heard your presentation. How difficult is it to get people from all these walks of lives and these paths of recovery into the same room, at the same table, to facilitate a conversation? I facilitate conversations all the time. Facilitating this type of conversation is interesting, it's important, but what was the challenge for you?
The biggest challenge for me was actually more so the first time we ever ran one of the panels. And so when I talk about when you're dealing with a client, you kind of have to swallow your own stuff and your own bias around recovery. I had to swallow my opposition towards 12 steps. I did. And the reason 12 steps got involved was because the CU Boulder representative was like, hey, if you're offering the options for recovery, you have to have 12 steps on the panel. And I said, you're totally right. Before that first event, though, we didn't. So when you have 12 steps represented in terms of like if you're looking at AA, NA, you actually have to have a public information person, so a PI, that can actually represent their program in such an educational manner. And I had a woman come in that kind of represented 12 steps in general. And I had a phone call with her a week prior to the event, and I told her my story, and I told her how transparent I am, and I said I would talk about that, because that's how it all started. And she was worried about me and said, don't talk about moderation to the audience, and don't talk about your story. But I'll totally be there if you want me on the panel. And I said, I will call you back. And every other person, I was like, yeah, get on the panel. But I had that, and it was a repeat of the conversation I had with a licensed professional counselor who was like, you're delusional, you're gonna hit your lowest low, all that stuff. And I called her back and I said, here's the thing, moderation management is on the panel. And you can also be represented on the panel, but I'm very careful about the language, and they can all kind of vouch to that. I'm very careful about the language we use on the panel, and I'm not going to sit back and watch a fight break out on the panel. And she said, she actually apologized. She had spoken about that conversation she had with me prior to having that other phone call, and she's like, I apologize, I attacked you like that, and I don't actually know your personal story and all that stuff, and I'll be on the panel. She got on the panel. Again, she wasn't a PI, so technically maybe shouldn't have been on the panel in the capacity that she was. But she was just talking about the general 12 steps, not representing any part of the organizations. And when the conversation started, and I can't even believe it, when everybody ran to the panel, she sat right next to MM. I mean, I did not even plan it. It just happened that way. And when the conversation started, she talked about 12 steps, 12 steps, 12 steps, 12 steps. By the end of the panel discussion, she talked about recovery. After the event, she approached me and said, I have a public information chairman for Narcotics Anonymous that can sit on your panel. That was the hardest part, and that was the hardest part was probably me having to swallow my own bias and to have that community swallow theirs as well. And then it worked. And the NA, there was a transition between the NA chairman lately, and the new individual emailed me and was like, hey, just so you know, I'm the chairman, I love choice and recovery, let me know if there's anything ever happening, like I want to be involved. And so it wasn't that hard after that happened, and my experience with any of the panelists has always been they completely believe in their own pathway. They're also able to believe in their own pathway and be okay with an audience member choosing a different pathway. And that comes from the conversations we have, that comes from training, and just everybody getting behind the same idea, because these people all represent a different pathway. you know, and it's great that they can sit here and be okay with the fact that they represent a different pathway and that I talk about moderation. Nobody ever approached me about that being an issue. And that's great, because that really shows me that we believe that there are different routes of recovery, especially when we're looking at recovery as an entire person. And do we have time for one more question? Cool. Yes?
Hi, I'm Carol O'Hare with Nevada Council on Problem Gambling. And I, too, coming from a 12-step background, personally and professionally, have had to expand and stretch and welcome people who use yoga to get better, and I am grateful for this panel to be here. We keep talking about different pathways to recovery. I'd like to ask each of the panelists, what about different addictions? Because gambling disorder is now the first behavioral disorder in the substance use and addictive disorders, which I thank this organization for being the Southern Nevada Addictive Disorders Project. What would happen if I, as a recovering compulsive gambler, or I had someone who wanted to seek your pathway, whose problem is gambling and is not a substance? Are you able to accept them?
Can
Are you
I,
willing to accept them?
With SMART, it's all about behavior. It doesn't matter what the addiction or the dependency is. It's
Right.
about how you yourself behave under certain conditions and why you do the things you do. It's not anything about alcohol. It's about shopping, sex, anything that is an
And I'm
addiction.
actually familiar with SMART, and I appreciate the science-based aspect of that. I'm particularly interested in women's sobriety, too, because my own 12-step experience was based in the fact that I found women in Gamblers Anonymous who understood I needed empowerment. I didn't need to be told by men that I was powerless. So,
Right.
sorry, that was a moment.
Just to touch on that, unfortunately, by very nature of our name, we deal with substances and alcohol abuse only, or use disorders. And we generally don't, it's not the best idea in our meetings to have women there that don't have problems with alcohol or substances, because if for some reason the woman with a gambling addiction or a sex addiction was to speak about, and my sex addiction goes off the hook when I drink, and well, you have women there that could be triggered by the fact of a woman talking about drinking, or that she drank last night, or that she always drinks before she does but that she doesn't have a problem with drinking, which is fine. But in other words, if her drinking is not a problem, her substance, well, most substance use would be a problem. But if her drinking is not a problem, she's at a fundamental, dichotomy there with the women who are there that are even sometimes triggered by someone speaking about drinking. So unfortunately, we just deal with alcohol and substance use.
We do celebrate, it's hurt, hang up, and habit. So we believe there's a hurt, you get hung up about that hurt, and then you form habits to deal with that. Only 30% of the participants nationwide are there for substance use disorder. 70% are there for other life disorder stuff. So we believe it's a systemic hole that we try to fill, and we have a large contingency of people who are in recovery from gambling addiction.
And I actually have to cut this off time-wise. If you guys have questions or anything, this is how you contact me, and here's the website for us. And then Nyla has offered being a resource here to connect to all the other resources like in the actual area, since I'm not from here. So her email is written up here. But yeah, thank you all, and we are totally done so.
I was just handed a note. You can pick up lunch outside the ballroom, eat inside the ballroom. There's a lunch presentation. But I wasn't told what time does it start and what is it?
There's no way.
Yeah, right.